Ken, I think you're holding a microphone. Ken, do you want to just introduce yourself? We'll just go through the 2 rows and then open this up.
Yeah, hi, I'm Ken Bauer. I'm a hematologist here in Boston, working at the Veterans Hospital and Beth Israel Deaconess in the Harvard system.
I'm Henry Bussey. I'm with the University of Texas at Austin and the Health Science Center in San Antonio, and also senior editor and co-founder of an interactive information service called clotcare.org, and also working on a new and better way to manage warfarin with self-testing and automated online management.
Hello, my name is Chuck Carter. I run a private organization in North Carolina, Research Triangle Park, named Pharmaceutical Strategic Initiatives, and I have been working in the thrombosis area both on research and education for the last 25 years.
My name is Geno Merli, and I'm at Thomas Jefferson University Hospital in Philadelphia. I hold 2 jobs. I'm the Chief Medical Officer for the hospital, and secondly, I'm the co-director of the Jefferson Vascular Center, where we have our anticoagulation program.
I'm Bob Pendleton. I'm a director of the hospitals program at University of Utah in Salt Lake City, and also I'm the medical director of our healthcare system's thrombosis service.
Hi, I'm Farzaneh Sorond. I'm a stroke specialist at the Brigham and Women's Hospital.
I'm Gregory Elliot. I'm the chairman of Department of Medicine at Intermountain Medical Center in Salt Lake City. I'm also the director of the Pulmonary Hypertension Center at Intermountain Medical Center.
I'm Paul Stein. I'm a cardiologist. I've been working in the field of pulmonary embolism for the last several years. I was a lot of years. Don't laugh. A lot of years. And I'm director of research at a community hospital in Detroit, and I'm also spent half time at Michigan State University.
My name is Julie Shay. I'm a nurse practitioner at Brigham and Women's Hospital, and I work with the cardiac arrhythmia service there.
Hi, my name is Dan Frank, and I'm just a patient.
Most important person here. My name is Mark Estes. I'm a cardiologist crosstown at Tufts Medical Center.
And I'm Karen Fiumara. I'm a pharmacist and the patient safety officer here at Brigham.
Great. Well, and a common thread here is everyone on the panel has a leadership role in NATF. But Dan, going back to you, I remember you were coming in for a routine visit with me. You'd already been my patient and friend for quite some time. And being in a cardiology practice, we sort of automatically do electrocardiograms in patients before they see their cardiologist, and that happened to you. And much to my surprise, there was a big change on the electrocardiogram and showed atrial fibrillation. I think I was seeing you once every 3 months. Can you tell us what did that mean to you, and what was your reaction to it, and how did your life change?
Well, I was nervous, but I'm always nervous. It changed actually for the good, because we started to do some things that we weren't doing before, like watching our weight, exercising, and when I say exercising, I mean exercising, and just more contact and better feelings about life, because Dr. Goldhaber insisted that I do certain things like stop smoking and things like that. And my life has become better because of what I've learned from Dr. Goldhaber and his staff.
I see Mrs. Frank in here. I wonder, did the diagnosis of atrial fibrillation have any effects on the inner family dynamics at all? Or?
He really is very boring. All he wants to do is eat healthy, exercise all the time, and he listens to his doctor.
Okay, I'm going to have Greg moderate the rest of the symposium, and then conclude the program.
Well, thanks, Sam. I think we're lucky to have Julie Shay up as part of the panel. I think you are modest, though. You do a lot more than just work with the Cardiac Arrhythmia Service. Why don't you tell us a little bit about what you do with so many patients that are affected by atrial fibrillation?
Well, how many of you in the room are aware that this September is National AF Awareness Month? One person in the back of the room, okay? The Heart Rhythm Society, which is our scientific body, is actually embarked on an initiative because they, like myself, are very interested in education, particularly for patients in terms of understanding what atrial fibrillation is, how to manage your lifestyle so that you can reduce the likelihood that you may have atrial fibrillation. So to that end, they developed, along with the government, this National AF Awareness Month. And they have a lot of initiatives trying to move that forward. I was actually had the Heart Rhythm Society in at the Brigham this week. We're creating an educational video for patients with atrial fibrillation, so very kind of comprehensive, looking at different types of management options, many of which you've seen presented here this evening, medical management, catheter ablation procedures, and integrated into that are patient stories. Patients anywhere from 37-year-old gentleman, very healthy, robust, who has atrial fibrillation and underwent an ablation, to an 89-year-old woman who was medically managed for her atrial fibrillation over the years, and how she kind of learned to modify her lifestyle and learned how to cope with atrial fibrillation. So I'm a big proponent of education. Back in 1999, I actually started our Living with Atrial Fibrillation program. Has anybody in the patients in the audience attended that? Great. Well, we are running a program this year, so can I give a little plug?
Yes, please.
For our program. It's going to be held on Saturday, October 29th at the Westin Copley Place Hotel. It's a half-day workshop, and there we have electrophysiologists from our facility. We go over the gamut of atrial fibrillation. It's a free workshop for anybody who wants to attend. You can bring family members with you. So if you are interested, you can go onto the Brigham website and get more information about that. But I think, education, knowledge is power, really understanding how to manage your atrial fibrillation. And to all the patients that are here this evening, kudos to you for coming out to learning more about it, as well as to the primary care physicians and the cardiologists that are here tonight. Kudos to you as well for wanting to learn more about the condition, because I think AF patients oftentimes are overlooked in terms of education and how to manage things more effectively to reduce bad outcomes and, most importantly, to improve their quality of life, because that's what this mostly is about. So, thank you.
Now, Julie, you're not off the hook just yet. We just spent the last few hours talking about all of the advances that have taken place in our understanding of atrial fibrillation and changes in the management of these patients and stroke prevention. I can imagine that patients must be coming to you with a thirst for knowledge in trying to find out what all of these new changes are. What are some of the common questions that you're getting these days?
Well, probably one of the biggest questions is why do I have this? What causes atrial fibrillation? And so we do review many of the causes, some which patients can modify things within their lifestyle, some that they can't. One of the biggest issues is obviously anticoagulation. Coumadin has always been the forefront of management for patients, and although it's been extremely effective, it does put a burden on people having to check their INRs all the time. So fortunately now we have some options for people using dabigatran. We've just started using it. It was just recently released a few months ago, so we're in the process of rolling patients over from Coumadin to dabigatran, those patients who are eligible for it. And then there's a lot of issues with coping, because this oftentimes can be a chronic problem, even though it comes and goes and comes and goes. And there's that kind of, fear behind it, like when is it going to happen? Am I going to be at a business meeting and all of a sudden I go into atrial fibrillation? So there's a lot of anxiety and depression that goes along with it as well. So providing counseling for that, I think, is very important, certainly part of my job. And again, that's what kind of made me want to run the Living with AF program, to provide patients with some peer support as well, knowing that they're not alone in this journey of living with atrial fibrillation. And hopefully, we have electrophysiologists like Dr. Estes who can hopefully reduce the likelihood by doing catheter-based procedures. I'm always a little hesitant to use the word cure with it. I'm very careful with it. I don't necessarily feel there's a silver bullet for treating atrial fibrillation. So I think it's important for patients to have realistic expectations about their atrial fibrillation and what their management plan is. But I've seen numerous patients coming into our program who have had catheter ablation and done extremely well afterward, and are very grateful for the fact that they've gone many years without having any recurrences of atrial fibrillation.
Oh, excellent. Thank you so much for those insights. And now I think you've all been waiting patiently to have your opportunity to ask questions to this great panel that we've assembled. I'd ask that you please use the microphones in the center of the room. And I leave the panel at your mercy.
Can I ask a quick question?
Yes.
Mic back on again. Thank you. I'm actually going to address this to Dr. Estes. I'm just curious, at your program, how do you monitor your patients post-ablation for recurrences of atrial fibrillation? We typically do some type of remote monitoring on them at a period of time, but I think we need something a little bit more robust, because as we're modifying the substrate, we have many patients that may have asymptomatic recurrences, and in terms of timing of taking them off Coumadin and current clinical trials and how that may impact things downstream.
Yeah, it's a key question and an important one. The standards that have been set up by the experts with the consensus document that came out from the Heart Rhythm Society in 2007 basically say that any patient who has an ablation, and it holds whether it's surgical or catheter-based, should be monitored closely, and there are a variety of techniques that can do it, one of which is symptoms, which we know is not very reliable. Routine evaluation with your physician with EKGs, techniques like ambulatory monitoring, where you might wear a 24-hour Holter monitor that records your heart rhythm for a full 24 hours, or increasingly we're using remote monitoring technologies in which small beeper-sized devices can be hooked up and very discreetly worn for a period of several weeks. And there are a variety of very specific protocols that we don't need to get into, but the 1 year free of antiarrhythmic agents and free of AFib is really the definition of success that's standardly there. And if I might, while I have the microphone too, just to get to a whole different issue too, which, we're spending a lot of time talking about treating existing AFib. That is, once people have had risk factors for many years and they develop it, starting up appropriate evaluation and treatment, sometimes ablation, sometimes antiarrhythmics, sometimes drugs to control the rate with appropriate anticoagulation. But in many respects, I think we need to refocus a little bit on prevention of AFib in the first place. And, as the slides that I'm sure Sam and other people showed about the projections over the next 20 years of AFib we look at, I think there's a real chance to really change that curve. And it's really coming with lifestyle modifications. Investing now in things like exercise and dietary counseling, getting weight down, decreasing hypertension, decreasing diabetes. In 10 years, we'll start to really make a big difference in preventing AFib. So many ways, the baby boomers, the 75 million people born between 1946 and 1964, who are just going to drive the AFib rates way up, we got it wrong. We got it completely wrong in terms of our diet, in terms of our exercise, in terms of obesity and hypertension. But finding good economic models that reward prevention now aren't easy in the current healthcare system, but they'll be embedded into the new healthcare systems. And I think we'll be looking not only at treating existing AFib, but changing the curve and preventing it as well.
Great, those were excellent insights. If the audience has questions.
Yes, I do.
Good.
I have a question about dabigatran. Being that all of the studies excluded patients with a creatinine clearance less than 30, and that the 75 milligram dose was never actually studied, I just want to see what your comfort level is in using dabigatran in the patient with a creatinine clearance less than 30.
I'll leave that up to the panel to decide who wants to tackle that. Dr. Merli?
Well, I can give you the easy answer. In our anticoagulation clinic, creatinine clearance is less than 30. We are not putting those patients on dabigatran. We sort of make it easy because I think once you start looking at that, unless we have a way to approach that process, I think there's always the risk to get that patient into trouble with the bleeding process that occurs. One step further on that, in the hospital setting, since Karen is responsible for safety and quality, what we decided to do with the pharmacy was to limit the use of dabigatran in the hospital setting to a select group of physicians. So it's restricted to cardiologists, hematologists. No one else can use the drug who practices at the hospital. They have to get essentially a request to do that. That does two things. It prevents us from putting patients on inadvertently who have renal impairment, putting them on dabigatran, and then resulting in a possible problem in a hospital setting. So we restricted the use of the drug. Pharmacy follows everyone that comes in on dabigatran to assure that they are not getting other concomitant anticoagulants. And so we have a registry. And so the doctors were not happy at my hospital to be restricted for use of this drug. And the only reason we did that is because we found that over the last 6 months that the use of dabigatran, attempts to use it for other indications such as heparin-induced thrombocytopenia, patients who had a stroke on warfarin and wanting to put them on dabigatran. We had multiple requests that I really never could have anticipated. So by restricting the drug, keeping it pretty strict in the outpatient setting as well, for specifically renal failure, age, and we don't use other doses, we sort of try to keep our hands around the process and have better quality and safety of a new agent. So that's a long-winded answer to your question, but we try to make it easy for the physicians, pharmacists who practice in our anticoagulation program, and other practices in the vicinity to have a more rational way to use it.
Great, that was a terrific question. Other questions from the audience?
This is for Dr. Estes. I've always been a person who's the first to say, I don't know. So that's what I have here. I don't know. Personal reason. The pharmacists have to answer questions to get continuing education credit. And question 6 concerns ablation. And talking with other pharmacists, either we missed it, all of us, or it never got covered. Fine, we're all saying it wasn't answered, so perhaps you could help us with that question. Do you mind reading it for Dr. Estes?
Which of the following statements is best supported by evidence related to AF ablation? A, AF ablation is effective in maintaining sinus rhythm in patients with heart failure and persistent AFib. That's no. AF is effective in maintaining sinus rhythm in patients with no structural heart disease and paroxysmal AFib. That's yes. Okay? And all the others are no. All right? You're very welcome. My apologies for not making that clearer in the lecture. But you can get your CME credits now. So B is the right answer.
Yes, if you wouldn't mind going to the microphone.
Very quick. Relationship to coffee, caffeine, and AF?
Well, if you look at large populations of patients, it doesn't really come out as a driver of AFib. However, if you speak to individual patients, it's very, very clear that caffeine, and sometimes it's coffee, sometimes it's actually cold caffeine in carbonated beverages that causes AFib. And it's much the same, I think, with alcohol as well. I've got some patients who literally take 2 or 3 sips of wine, in 2 or 3 hours, they're predictably in AFib. So it's variable by patient. You should all look at the triggers that you think are important for you and avoid them. Physical activity that's extreme in some instances will cause AFib. Mental stress will cause AFib in some people as well. I've got many of my colleagues in cardiology, after 2 or 3 very busy nights in the hospital, will predictably go into AFib. So physical and mental stress will do it as well. And you'll always want to start with the basics, which is eliminate the trigger. And in many instances, that trigger is too much salt in your diet, a little bit too much weight, driving the high blood pressure, which drives AFib as well. So the basics are really try to prevent it with lifestyle modifications that are variable by individual, but most patients have a pretty good sense of what they are. Good question.
Of course.
Would you expand on where does the risk come from? Why, if you cure somebody who has no failure, he's early stage atrial fibrillation, you've got a cure, no left ventricular enlargement, no left atrial enlargement, no recurrence, at least you could monitor for recurrence of atrial fibrillation. Why do you need to continue anticoagulants? Where is the stroke going to come from? And how long do you need to continue anticoagulants? And where does the balance come in, knowing that there's about a 2% risk of a serious bleed every year? 10 years, you got 20% risk of bleed.
Well, yeah, these are terrific questions, and the best available evidence comes actually from the trials which were reviewed looking at patients who are randomized to a rate control strategy versus a rhythm control strategy. And if they were in sinus rhythm on an antiarrhythmic agent and came off the warfarin, their stroke risk was identical to people who were in AFib. And it's from that data that we extrapolate in the patient population after AFib ablation, because the fact is that probably many of these people are still having AFib after the ablation, but it's minimally symptomatic or asymptomatic. It's occult, they don't feel it. And if they have a CHAD score of 2, they're exposed to a risk of stroke. There are probably selected patients with CHAD scores of 1 or 0 who very appropriate to withdraw the anticoagulation. But the best available evidence, and it's limited, would say that if you've got a CHAD score of 2 and you have an AFib ablation and you're cured, you still should stay on the anticoagulation.
Got it. I would think if I were the patient, I could find, and you could too, find some unique way of monitoring. Heck, I'll buy my own EKG machine and take a rhythm strip every day to avoid the...
Well, it's a good point, and of course every patient, has to make their own decisions. We guide, you decide, and there are many patients who just don't like being on warfarin and decide that despite perhaps a risk of stroke, they're going to stop it because they just don't like being on it. I think we'll get much better evidence as we move forward, because there are good tools for monitoring patients' heart rhythms even while they're sleeping continuously with these external devices. And I think we'll get better at selecting patients that we can stop the warfarin. But in the setting of uncertainty, I think most physicians would err on the side of anticoagulation with meticulous control, because strokes are terrible things. They can be fatal, they can be debilitating. And it's frankly rare these days that with appropriate monitoring and patient education that people have fatal or life-altering bleeds on warfarin or other drugs. So in the setting of uncertainty, I think most of us would favor with very, very careful anticoagulation for stroke prevention because of the great fear of strokes. But we don't have all those answers. They're great questions.
Hi, my name is Renelle. I'm a pharmacist here at Brigham and Women's Anticoagulation Service. I have a question for Dr. Estes. I just wanted, or anyone who would like to weigh in. What is your thought on pill-in-the-pocket use of dabigatran, sort of PRN dabigatran, if you will? I've seen a couple of people subscribe to this theory, and I was wondering if perhaps you could rationalize it out. We have a panel of experts, so I was hoping for some insight.
I'm not aware of any data with pill-in-the-pocket dabigatran. There would be risk, no proven benefit. I wouldn't do it. I wouldn't recommend it. But there may be some data I'm unaware of, which I think somebody else in this room would know about. Sam, are you aware of any? No, I would, yeah, are no data. And it's really not a good alternative to what we know works?
I'd just add maybe a word of caution. I'm concerned about the increased MI that was reported with RELY, particularly since 20 to 40% of those patients were on aspirin. And we know from the zimalagatran data that zimalagatran with aspirin reduced MI rate. So I'm concerned about what would the MI rate have been had they not had widespread use of aspirin. Plus, one of the earlier dabigatran studies did show an increase in urinary thromboxane levels. And I don't know if that was due to the drug promoting thromboxane synthesis or whether it was due to the offset of the drug. But I think we've got, you know, some maybe weak indicators to make us worry about that.
Excellent. We have time for one more question.
To the panel, and you know, I, as a stroke neurologist, we've long been waiting for something besides warfarin that would provide more stroke prevention benefit for our patients. But with the dabigatran, I'm a little concerned, and my question is, how do you now educate the patients that you've prescribed dabigatran to in terms of what happens if they have an onset of stroke symptoms? I hope that it's, you know, stroke education is part of all anticoagulation clinics to tell them to come in within 3 hours of symptom onset, to make sure that they don't wait around. They call 911 because of the thrombolytics. So what do we tell them now? What do we do with these patients when they come into the emergency room with acute stroke symptoms within 3 to 6 hours of symptom onset?
Neurologists have asked the same question at our facility. And what they've done with thrombolytics is if you're taking, we've not had anyone taking dabigatran who's had a new stroke and they had to decide if they were going to use thrombolytics or not. The plan is, from the neurology leadership, is if you're on dabigatran and you have new onset strokes, you're not to get thrombolytic therapy until they sort out, and of course they've passed the window by that time period. So they've sort of made it as simple as possible, but they don't know what to do with this. So sort of just like the same question is, I just took my Pradaxa or dabigatran this morning and I get acute coronary syndrome and I'm in the cath lab. Do I get heparin for the cath or not? How do I know where my anticoagulation is? The cardiologists think that all the time. So our cardiologist did an ACT and they found that it was over 350 seconds. But they weren't sure what that meant, so anyway, it's like sort of interesting. But so our approach has been no thrombolytics if you're on dabigatran.
So, but I mean, just no intra-arterial thrombolytics?
Yes, and we do catheter directed now.
Yeah, I guess at University of Utah, we've taken a proactive approach, and with regards to the patient education element, when patients are switched over to dabigatran, they still are followed systematically by our thrombosis service. So rather than monthly INRs, patients are still contacted on a quarterly basis and education's reinforced. We've also had education efforts directed at our first responders in the emergency department to recognize that someone coming in on dabigatran with either an acute thrombotic event or a bleeding event, that we can't rely on our sort of normal coagulation tests, our INR and our PTT. For your particular case, we felt strongly that having as much accurate information helps us guide the best possible decisions in the acute setting, and so we have validated a highly sensitive thrombin time as it relates specifically to dabigatran so that we can know whether or not someone has substantial amounts of anticoagulation on board. In a patient with acute stroke, if their thrombin time was normal and we're still within that time window, then there really would be no contraindication to giving thrombolytics.
And how fast do you get that thrombin time back?
Well, our thrombin time we get back within 30 minutes. So it's truly a stat test that our hospital manages and handles, similar to a stat INR or PTT.
Excellent. Well, I think we should give our panel a warm round of applause for